the need for is emphasizing the need for communicating a bad news, and what are the challenges that we generally face, and in terms of patient's perspective as well as healthcare professionals' perspective. So now we are just going to look into two specific issues that we encounter very commonly. So the first one is collusion. So I think this is something that all of us as healthcare professionals would have encountered, and this is something that we keep encountering every day, irrespective of the situation. Be it is it if it is end of life care, or even if it is just disclosing a diagnosis, even if it is in a very curative stage as well. So this is a very common phenomena that all of us encounter in day to day practice. So, just introducing a little bit about collusion. So, to speak about this, first we would see in detail about the non-disclosure model. So, non-disclosure model is basically, when the healthcare professional himself or herself decides that they are not going to reveal the news to the patient. So, it could be because of the healthcare professional's own limitations or their own factors, or it could be because of the pressure from from their family as well. So in this case, when the doctor decides that, I'm a very kind-hearted person, or I generally do not disclose anything to my patients. I do not break their hope. So that's the non-disclosure aspect. Whereas the patient would want to know, what is going on with them, what is wrong with them. So this could create a lot of uncertainty, which could eventually lead to a lot of distress. So this is the first scenario that happens, and this is unfortunately quite common in our culture. The second scenario is when the healthcare professional wants to reveal the news to the patient or the family, meaning that I go by ethics, and I always want to know would want my patients to know what is going on. I just follow the practice, and so if that is the case, then the healthcare professional just goes about with revealing the news to the patient or the caregiver, whereas the patient is not in the condition to actually receive the news and process it. So sometimes, patients would come and say, just, I really don't want to know anything. Just let me be in peace. I will just, whatever it is, you just discuss with my family, discuss with my son or daughter. I don't want to know anything. So that would be the case. But then the doctor would be like, no, no, actually, according to the ethics, you must have to know. You will have to decide what is it that you want. So, it's my duty. I just have to tell you what's going on. So that is the second scenario in collusion. And but the most ideal thing that should happen is when the healthcare professional is finding out what exactly the patient wants to know, and if the patient wants to know at all. So understanding the need for information, and then again exploring what kind of information the patient wants to know. So information no revealing should depend on the recipient's state of mind and their current scenario, and the information should be tailored accordingly. It should not be just going with one sort of flow. It should always be tailored to whether the patient is illiterate, patient is literate, or sometimes patient would be literate, and the family would be telling us that she does not know anything, we have not told her anything. So but then patient would be very much aware that she is in a cancer setting, and she's oncologists are seeing her, or at least someone would have uttered the word cancer in front of her. She could have processed information, but then the caregivers would think that the patient is blindsided and not aware of anything. So we have to first identify what are the patient's factors, and evaluate whether the patient wants to know. If yes, then what kind of information the patient wants to know, and how much information must be revealed to the patient. So this is where this is what the ideal scenario comes in. The first two scenarios that we discussed, wherein the doctor wants to discuss but the patient does not want to know, the no, doctor does not want to discuss but the patient wants to know. This is very similar to with even caregivers. because here not all the time the doctors are the decision makers in this setting. So most of the times it's the caregivers also most of the times it's actually the caregivers who make the call of whether telling the patient or not. So that is what happens in our regular practice. So basically, why collusion happens, why this happens is that, before trying to break collusion, we have to understand what is the reason behind this collusion, why so much of pressure on this. So when a family is trying to withhold some information from the patient, we have to understand that it is their attempt to buffer the patient's distress. They are just trying to ensure that the patient's psychological state is not disturbed and that their hope is not broken, so that will give them the preparedness and readiness to actually deal with the scenario. So it is not that the family is doing it very irrationally. It is with an ulterior motive of just buffering the patient's distress. At least they feel that, as long as they don't know, they would have better state of mind. That is what the family's assumption is. So that is only with that notion, generally, a family comes to a healthcare professional and says that, my father or mother does not know anything, so do not disclose anything to them. So that is with regard to family or caregivers. But what is it that with regard to doctors or healthcare professionals is that in Western culture, doctors actually internalize the reason for the collusion, meaning the doctors, healthcare professionals, more commonly feel that they are not equipped with handling the information, like the aftermath of revealing the diagnosis or the prognosis. So they say that I am actually scared to tell this because I don't know how to handle when a patient starts crying, or I feel bad for breaking someone's hope. So they internalize a lot when trying to explore what is the reason for this collusion. Whereas in Asian culture, in our culture, externalizes on carers. So when they try to understand what is the reason here for the doctors not revealing, most of the times doctors or healthcare professionals, they externalize the reason to the family members. They say that my no the relatives no requested not to reveal, so I did not reveal. So that's why we didn't want to go ahead with that. So most of the scenarios they externalized, saying that it is because of this. So that is where a lot of mistrust starts generating. So the patient would have a lot of assumptions, but they don't know what information is coming, whether the information is genuine or not. So there are a lot of factors. So collusion happens basically either because of the caregivers or because of the healthcare professionals, and not because of patients actually. Hello, is someone trying to speak? Okay. So, these are the factors that causes collusion in our healthcare setting. So we have to understand what is the reason why so much, why this confusion in communicating an information to a patient. So, okay, so there is a collusion, right? So then, why should we actually break the collusion? Why should we try to resolve this situation? Because collusion actually slowly leads to distrust and mistruth, which later starts affecting the interpersonal relationship between patients and caregivers. So what happens is when a patient starts but I feel that there is much more that I should know. In that case, then this withholding of information could slowly develop into a distrust. So the patient will start withdrawing from any social circle, think that I'm not going to trust anything that is coming from the doctors or patient. How can I trust if they are telling me the truth? So this will start interfering a lot when we go ahead with treatment planning or adherence to treatment, because that distrust between a healthcare professional and patient will definitely lead to a lot of consequences as through the cancer continuum. So That's the first point. The next one is it can lead to anger in the patient when collusion is detected and creates an environment of suspicion. So, as I said, it's not just distrust, it also leads to anger outburst, because they'll sometimes patients would start even fighting with the caregiver, saying this, you did not tell me this, how, I didn't want this treatment, or I wanted this treatment. So, there will be a lot of anger outbursts that would reflect with the healthcare professionals as well when the collusion is detected, because we have to clearly understand that cancer is not, or cancer or any chronic illness situation is not a very brief scenario which is going to end in 2 to 3 days or something, so that you can keep the patient in blind side. But thing is, eventually there will be a lot of physical implications as treatment proceeds. There are going to be a lot of psychosocial issues that's going to arise. So in that case, uh, uh, like you know there would be some scenarios where the patient starts suspecting that something is not right. Something, the doctors are telling me something, but I don't feel that is in line with what is actually happening with my health. So there would be scenarios which gives away what exactly is happening. So when that situation occurs, that's going to create a lot of chaos. So most of the times, open and honest communication is not harmful. So what we think is, once we are being honest and open about what is happening, that's going to harm the patient. But that is actually, it's a misconception, and it's going to only benefit the patients and relatives. Like how? Yes, of course, there are going to be some short-term effects of honest communication. So when we are disclosing that, that this is the diagnosis, or this is the prognosis, that it's not in a very good shape. So in that case, there are going to be emotional outbursts. There is going to be demoralization. Patients would have anger outbursts. There will be a lot of emotional, reactions to it, disparity, depression. So this definitely would happen. We cannot expect people to just be very open to what's going on, and then just accept it very smoothly. So that is going to be, yes, short term effects of it. But that discussion is also going to be accompanied by unfinished business, discussion of unfinished business and emotions, and that is what is going to help them plan the future. So once they cross this emotional reaction phase, that is when the patient or the family would be in a state to actually rationally think about what is it that they want to do and what is going to happen. So that would help develop the actual care of plan that the patient, that is tailored to the patient. So that will happen only if we cross this scenario. And again, but one important factor in this is, this should not be made as your agenda, meaning the healthcare should professionals must not always go the fact that there is a collusion, and I just have to go ahead and break it to the patient, and I'm not going to leave the scenario like this. Or again, the family is doesn't want to do, so I'm not going to do with this. So it should not be the way that it becomes a healthcare professional's point of view. So wherever, it should always, the pollution breaking or the communication discussion should always revolve around patients preference and patients point of view. Okay. So okay, if that's the case, what should you do so in order to break this collusion? So first thing is, when you encounter a caregiver who is requesting you not to reveal any diagnosis or prognosis to the patient, in that case, first thing is, you should not challenge their belief. So do not go ahead and tell them that uh, how can you say this, or what you think is wrong. So do not challenge, but acknowledge why they are doing that. Okay. So meaning, we have to understand their point of view and verbalize that. Say that, I understand that you're trying to do this to buffer the patient's distress. I understand that you're keeping the patient's well-being, as a consideration here. But then, so you have to then introduce the importance of breaking the collusion. and again agree to collude. So it should not be going against the caregiver's point of view, saying this, I don't care what I don't care what you say, but I'm just going to go ahead and tell the patient because that's my duty as a healthcare professional. So that should not be the way. You have to agree to collude because it's going to be a teamwork, particularly because you're going to disclose the information, and after which the caregivers have to handle the aftermath. So you need to have them as part of the discussion as well. And next is earn their trust. So to gain the trust, because we have to understand why the caregivers are doing this. They, definitely they don't know how the patient is going to react to the information. So in that case, they have to, develop a trust on us. They have to know that, okay, I know that, this person is not going to break it to my mother. This person is not going to do this. Like, I know that this is what she's going to tell, and I know she's going to be there, afterwards to handle this. So that trust should be developed, for which you can also tell that, when we discuss, you can be here, like, you can also be there, so that you get to see or know what actually I'm telling the patient. So this is what we are going to disclose to the patient, and you can be there so that you will also know how the patient is reacting to it. And we will be discussing only about this. So that's the contract that you develop with the caregivers when you are agreeing for a collusion, like, breaking a collusion. And then be prepared to face failures as well, because sometimes what happens is, even with few frequent attempts, still there would be some challenges from the caregivers itself. There will be certain scenarios where the caregivers are very, very adamant of not disclosing it. And there would be certain scenarios where we would not be able to do justice to the patient's need. Yes, that would be there. Not all the time we will be able to be successful in going ahead and breaking the collusion. Or sometimes you would be having an assumption that the patient wants to know, but then actually when you start disclosing, sometimes there will be challenges from the patient saying this, no, I really don't want to know, or this is something. And sometimes there would be an emotional outburst as well, which was something that you were not prepared for. So there would be, yes, challenges. So it is okay, like, we have to be prepared and say this, yes, there are going to be some challenges, and there would be sometimes failures too. So be prepared to face failures as well. So, breaking the collusion. So again, how we go about it is that first understand what the patient and the relative know. So, before, going ahead with this, so I would eventually take it forward because I would explain it along with the model. So breaking the bad news. So now we know, like, why collusion happens, and what exactly, like, we have to do before moving ahead with the patients. Like, how exactly should you prepare the caregiver, and what are the things that you have to speak with the caregiver in order to understand and plan the, handling collusion. So, again, why exactly is it important to break the bad news? Like, or, what should you do when it comes to breaking the bad news? Now that you have prepared the caregiver, when you're actually encountering the patient, like, what are the things that you have to keep in mind before? Is that do not avoid seeing the patient or leave them anxiously waiting for news. Like, sometimes what happens is you might not go prepared with all the information. So there would be some things that, you just leave it hanging. Say this is something that, I have to, like, I'm not very sure about it. So, like, I'll keep it waiting, or I'll come back with that information. So something, if the patient is asking and you're not prepared for it, that is okay. But then when you are going with the set of information, try to collect as much information as possible that the patient might require, and then go. Do not leave information in hanging. And you need privacy. There should not be any interruption. So this is very, very important. Considering that, healthcare setting, it's always a busy place wherein there will be people coming in and going. But then when we are disclosing some information or a bad news, ensure that you are in the place which has a very minimal, interruption. And be factual, like, and also be very empathetic. Give them the right information with ensure that you are empathetic. If you're not in the state of mind to feel empathetic, if you have any personal factors, then do not commit to doing the breaking of bad news that time, because anything doing half done is it's worse than actually it will definitely create a lot of psychosocial effects on the patient. So might as well we can postpone and have a session when you are also in the right state of mind. So again, give time for the information to sink in and the opportunity to ask questions. So you need to give time. So you cannot, again, when you're planning a discussion session, you cannot say this, I have 10 minutes, so I think I can quickly speak to this patient about her treatment plan. I can quickly have a discussion about her diagnosis. That should not be the case. You need to have adequate time, because you don't know what the patient is going to ask. So do not, if you feel like you need more time, just give the appointment to the patient, say this, we can have a discussion about this at 2 o'clock. I would come and I'll see you, or you can come here and we will discuss in detail about what is it that's going to go forward. So that's the next point. And if the patient does not seem to able to take any more, be prepared to end the conversation, and you can always take later. Based on your personal commitments, you cannot schedule the session. You can't say that I do not have time later, so I just have to push through and give you all the information. So that should not be the case. If you feel the patient is having a lot of emotional reaction or overwhelming, stop the consultation. Say this, I think that you're feeling overwhelmed, so is is there something, do you need some space? You can always stop in the conversation and say this, we can always resume when you feel better. So you can take it up later also. And again, do not give any precise information. Meaning, if the patient is asking how long am I going to live? So do not give like 6 weeks or 3 months, because when you say 3 months for the patient, it's like it's 3 months. That's a very fixed time for them. They do not think that it could be 2 months or it could be even 5 months. So they go with 3 months. So for them, actually they will start calculating the actual 3 months. So do not give any precise information. So for them, in their shoes, that is going to be like an actual fact that you're giving. So say that probably you can say this, sorry that will not be able to answer the question because it's very uncertain. You can also leave it like that instead of giving very precise information for things that are not very precise. And never say that nothing can be done. So always say this, because now we do have a lot of palliative care support, end of life care support. So even in situations where actual or treatment is not possible, we do have a lot of supportive treatments and therapies that are available. Yeah. So at least do not ever say this, "I'm sorry, nothing can be done for this." So always say this, there are ways that there would the hospitals would support you, the doctors would support you in case if something arises. If there is something that can be done, we can always try and do it. So just do not say this complete statement of nothing can be done. And again, while trying to be positive, do not lose track of what is actually fact. And also yeah, that is it. So these are the things that you have to keep in mind before going ahead with the discussion. So how to go about it? So now that we know collusion and now that we know what are the things to keep in mind before, so what are the ways to do it, or how exactly should we do it? So I would be discussing in detail about one model, that is the spikes, which I think most of you would be very familiar with. So, but before moving on to spikes, there is just one like to add is any information discussion, anything that you're trying to disclose or discuss, always keep this in mind. It's ask, tell, ask approach. So meaning, whenever you're sitting in front of a patient and you're prepared to give some information to the patient, first thing is ask them what is it that they want to know. So based on the question, tell, convey the information. And then after conveying the information, again ask. Ask meaning whether they understood what is being told to them. So like, just keep in mind these three words before setting up any situation where you're going to discuss the prognosis or diagnosis with the patient. So coming to the spikes model, so spikes, we all know that it's an acronym which stands for setting the interview, and then assessing patients perception, obtaining invitation, giving knowledge, addressing emotions, and strategy and summary. So we'll just be looking into the details. So the first one is setting up the interview, meaning when you're trying to disclose this information to the patient or the caregiver, ensure that it's in a very comfortable space for the patient as well as the caregiver, and it should ensure privacy. And again, if there are going to be more people involved in the process of decision making, ensure that all the people are involved at one go. Like no, yesterday, day before yesterday, also we were discussing a scenario where every day each caregiver keeps coming up, and it's like it just takes a lot of time when you have to disclose everything again and again. So just involve the primary people who are going to be the decision maker, and any other caregiver you can always direct them to the caregivers who have already discussed. You can say this, everything has been discussed with this person, so you can get the information from them. So involve everyone together at one place, and then look attentive and calm, and make sure that you're more focused on the listening aspect. And again, ensure that you're completely available for the patient. So you should not have prayer commitments. You should not be distracted with your own personal commitments during that time. So that time that you have given to the patient caregiver, you have to make sure that you are available for them. So completely until the conversation is over. So after setting the interview, next is perception. So understanding the perception, meaning if when we are trying to open up a conversation with the patient, ask them what is it that they know already about their health condition. So like how much do they know about their health condition? How much do they know about the prognosis and about the treatment plans that are further? So just, keep it very open-ended and ask questions to understand, unless you
Dr. Revathy, can you hear us? We couldn't hear you, Dr. Revathy. I hope it is the same for other participants too. Please comment in the chat box. Please go ahead.
Okay. Okay, thank you. So, yes, we were speaking about perception. So, trying to understand what exactly the patient knows already about the diagnosis and the prognosis. So, just keep it very open-ended and obtain the information based on trying to understand what is it that they are already aware of, so that you need not repeat the entire information again and again. You don't have to, if the patient is already aware of the diagnosis, you need not again repeat the same thing, so that you can just start from that point. You can say this, so as you already know that you've been diagnosed with cancer, so we would start discussing about what the prognosis is actually. So for that thing, you need to know what the patient is already aware of. And the next one is obtaining invitation, meaning trying to understand what exactly the patient wants to know from us, because some would like to know about the diagnosis or some about the treatment plan, some would want to know about the prognosis aspect. So what exactly do they want to know? Not every patient wants to know every information, so that differs a lot, because some patients would just say that I would like to know, like how long will I be cured or not, because I just have my daughter's wedding planned. I just want to know, will I be there around to do things for her? So, or I just want to be there until my son completes his education. So there would be things that are specifically, that they would want to plan. So there would be, information which are very specific that the patient wants to know. Not everyone would want to know all the information all the time. So it's very important for us to understand What is it that the patient would like to know from us so that we can tailor the information accordingly. And the next one is providing knowledge, meaning based on the questions raised by the patients. So, whether it is about the diagnosis or is it about the prognosis, so anything, based on that, we have to tailor the information and provide it in small warning shots. So do not just club all the information together and just go about it in one go. So give one information at a time and see how the patient reacts to it, and try to mirror the language the patient uses. If the patient is not uttering the word cancer, because sometimes in our setting we encounter this a lot, patients would say this, like they just use the word katti because they don't want to spell cancer because it's a very stigmatized word. So in that case, when the patient is more comfortable with using that language, even though they would be aware that it's cancerous, but they don't want to use the term it's cancer. So again, we should not be using the term cancer. So it will be more easy for them to process information if it is in the language it's very comfortable for them. So mirror the terms, mirror the language that the patient uses, and avoid using any jargons. So break the main purpose of this communication is to make the patient understand what they are dealing. So in that case, avoid any jargons and give the information in small chunks, and try to use silence also in between. Meaning, just because it is information provision, you don't have to just keep on going with the information. Give time for the patient to react and respond to what we have said. So use silence, like give gaps in between also, and allow time for emotions. So this is information, providing information. So first we start with setting up the interview, and then understanding the perception, what the patient knows already, and then we have to evaluate what the patient wants to know, and then provide the information accordingly. So the job is not done here. Just because we provide education, provide the knowledge, it's not over. Addressing emotions, breaking the bad news itself, accompanies with a lot of emotional reactions. So you have to recognize what the emotions are, what the patient feels, and how the patient feels. So listen and identify the emotion. If the patient is feeling sad, if the patient is feeling angry, or give space for that and just ask him, so how are you feeling now? What is it? What is going on in your mind right now? So, and if you're able to find the emotion, name the emotion. So tell them that I understand that you're feeling sad, I understand that you're feeling angry. So you can name the emotion also. That will, like you know I know. And also, if possible, tell them that I know, hearing such things would definitely make you sad. So when you tell them the origin of the emotion as well, they would feel more understood. They feel like, oh, she knows that I'm dealing with this, she knows that I'm going through with this. So that would give them validation for their emotion, so that they would not feel very withdrawn, they would be comfortable in expressing their emotion. And then once you give that space for emotion, all the catharsis and vent out, you don't have to, give solution. You don't have to address, say this, why don't you think that, why don't you think this? Nothing. Just give the space for their emotional vent out. So once they have just, just make them speak, ask them, okay, is there something that you would like to say? Is there something that you want to share? So just, give that space. And then once things have settled down, once the emotions have settled down, then summarize whatever has been done so far. Tell them that, initially you had knew about this, and then you wanted to know about these things. So I have told you about these things. These are the options that are available. So then, so far, do you have anything else to add? If nothing, then we can again, I'll come and see you again day after tomorrow or tomorrow by this time. So if there's anything, you can always, you can get back to me. So give that conclusion summary, so that they, like, that would give a complete process of what exactly happened. So they are not lost in the process of emotional reactions. That would give a closure for the session. So this is how, breaking the bad news generally should happen. It's a more ideal way to happen. And most of the models follow the same procedure. Even if you consider case model, so that would also follow the same pattern. Would start with what the patient knows, and is there something that they would want to know, and then giving warning shots, and then addressing the emotions, and giving space for ventilation. So many things, and then summary ends with summary and plan. So the basic, the concrete a plan is these steps. So any model would always follow these steps, but with some details added and removed. So this is about collusion. And then moving on to, so yes, you have already broken the news to the patient. So what happens next is the DABDA. So I think you would have heard about this as well. So DABDA is a model, it's a grief model which was given by uh, Kubler-Ross. And actually there are a lot of additions to it right now, and there are also repetitions to in the DABDA model. So I would just, give you a brief outlook on what exactly the data is. So it starts with whenever there is a news broken to someone. It's not only in cancer setting, not only in healthcare setting, but also, when anyone is told anything, even if we get a news which is very disheartening to us, we go through the same process. So it starts with denial. So denial is where, initially when news is given, we do not accept that is the reality. So initial stage where the individuals actually refuse to accept the reality of the loss. So it's more of a defense mechanism where they don't want to say this is actually happened. So once you tell the patient, you would have heard them telling this, no, no, cancer, no, no, that can't be happening to me, I don't have any habits, so there must be some mistake, or I cannot agree, so that is not wrong, the reports are wrong. So these would be the statements, in terms of denial. So denial is more, it's actually it's more of a defense mechanism, but unfortunately that's not a very healthy defense mechanism. And most of the times people do not get stuck in denial phase, but there are few cases where you would have patients who are lingering in the denial phase for a longer time. So in that case, once the initial news has come, for first few days, some people 1 day, some people 2 3 days, they would still be in the denial phase. But then once they keep getting exposed to the same scenario, that is happening, they're there in the hospital every day, doctors coming and talking to them about cancer, about treatment, about the situations that are happening around, they slowly start moving on to the next phase. That is the anger, because everyone is coming and insisting on the same thing, saying this, this is, yes, it is cancer. Yes, you have been diagnosed with this. This is what the treatment plan is. So when these things keep coming again and again, then slowly the denial begins to wear off and the reality starts settling in. So when reality starts settling in, the feelings of helplessness and frustration slowly leads to anger, saying this, why did this happen to me, this is so unfair, I've not done anything. So they would start showing their anger. Some people would show it, most of the times patients would start showing it towards the caregivers, and in some cases patients would show it to themselves. They would say this, why did I do this that time, I should not have done this, or I should have come to the hospital early. So many things they would start showing their anger towards. And sometimes even patients would start projecting their anger towards god, or even spiritual aspects. So you would have seen patients telling this, I've been such a good devotee, I've done so many pujas, I have done so many prayers, but why did god do this to me? So god is so unfair, I'm not going to pray to him anymore. So these are all just displacement of the frustration and helpless feeling that they have. So that is the anger. But once anger again does not stay around for a longer time, so that slowly moves on and becomes bargaining. So when still things have not changed and the reality is happening, then slowly they start moving in towards bargaining phase, wherein they would start discussing, negotiating with themselves, or with some higher power, just to escape the situation. They would say this, if I had gone to the hospital 1 day before, then probably things would have been different. Or if I had not done this that day, or if I had not played cricket that day. I would not have fallen down. This would not have happened. So many things. They would start bargaining that if this happens, then the situation would get reversed. So and they also start bargaining with God, saying this if you just bring him back, if you just make him better, I'll do anything that I can. So that is the bargaining phase, because that's a way to for them to last attempt for them to try and reverse the situation. So that is the bargaining. And then after bargaining, but still they feel that things are not changing and this is what the reality is, then slowly they move into the depressive phase. This depressive phase is not the clinical depression, but it is more of the depressive phase in terms of emotional reactions, wherein they slowly start accepting and experiencing the sadness of the situation, meaning this is what it is, it's not changing. So there will be lot of emotional reactions, accepting the situation, and how will I live after this, how will I do after this, I wanted to do this in my life. I wanted my daughter to get married. I want this to happen. So all the emotions that they have, projected and displaced, the actual emotions start settling in. So that is when they go into the depressive withdrawn phase. And after this emotional reaction comes the acceptance phase. So acceptance is when the emotions start getting settled, and they start coming in terms with the loss that's going to happen or the bad news, saying this, I understand this is not going to happen anymore. So anyway, this is the reality. So I just have to face it. I just have to deal with it myself. So there is no other option. So that is the acceptance phase. And that is where rational thinking starts settling in. Until then, you cannot expect any rationalization from the patient. So this is the processing of information. So, but in between in this, when at each and every phase, there would be things, that would be challenging, be it in anger, because in denial, questions that patients ask, we might not be able to give answers to. Saying this, no, no, did you take the reports again? Did you check the reports again? I could not have cancer. How will I have cancer? I have such a healthy lifestyle. So many things to contradict. So, not every place, every situation you will be having any responses to. And same way when it comes to anger, when patients start, once you break the bad news to the patient, they start expressing a lot of emotions outwardly directed towards the healthcare professionals. There will be patients fighting with us, fighting with the caregivers. So in such cases, we have to understand, do not see the emotion as an anger. Don't say this patient is very patient is like that, patient is just temperamental, so she's not going she's going to react this way. So do not brand or label the patient that way. We have to understand why this emotion arises. So in this case, during the breaking of bad news, when there is an anger or any emotional reaction, always understand that it is because of the news that is being given, which is not in line with what they actually expected. So that time emotions can arise, and that would be there. And none of these emotions are the actual emotions. They are all masked emotions. So what should you do when you actually encounter such emotion is that, first thing is name the emotion. So when the patient is fighting or arguing with you, or coming and crying with you, whatever it is, just name the emotion. Tell them that it looks like no, I can understand that you're feeling angry. I can understand, or I can see that you're feeling sad. So name the emotion, because when you give a name, patient itself is not aware of what is going on with them. They themselves are not knowing why they are reacting that way. So just first put a name to it, so that I can understand that you are feeling angry, at this situation. And again, after naming, understand, uh, tell them that yes, what you're feeling is genuine, what you're feeling is valid. So I cannot imagine how it feels to hear this. I can surely understand that no, it's a very big news for you. So acknowledge and understand that they are feeling, what they are feeling is very, very valid emotion. And then respect again. So tell them that you are asking the right questions, and what you're asking is very true. And just acknowledge that if the patient is telling this, you should have done the MRI before. Why did you do the test before? That is why the cancer has spread now. So if they're coming, tell them that you're asking the right questions. I can understand why you're feeling this way. I can understand that this is a very big thing for you. So name, understand, and then acknowledge whatever they are telling, and support. So extend, tell them that I'm here for you to, no matter what happens, like whatever it is, whatever kind of support that you need, we as a team are here to help you in whatever possible ways that we can. And try to explore, ask them, tell me more about how you're feeling. So that is providing space for them to, because anger is not always a genuine anger. It is a masked emotion of sadness. Most of the times in our culture, you have to understand that sadness is a very prohibited emotion. Not everyone is very comfortable with showing sadness or uh, distress directly outside. So anger is always shown as a very bold emotion. So most of the times, anger is expressed as a masked emotion of sadness. So once you give that space, you do not engage in an anger reaction. You give the space and acknowledge their emotion, and you tell them that this is what it is, and this is, yes, what you're feeling is very right. So okay, so tell me more about it. Tell me what more are you feeling. So once you give that space, slowly the anger passes moving out, and the actual emotion starts coming out. So that is more important. So just keep in mind that whatever, when you're engaging in a breaking of bad news or a discussion, end of life discussions, whatever it is, always keep in mind that it is not just about providing information, but also paying equal attention to the emotions. And most of the times, you do not need to, get in and give solutions. All they need is to just provide a platform for them to vent out, ask questions, and get clarified. That is what it is. But then beyond, certain things, like there is nothing that the patient is expecting you to get into their family and solve the issues. Not that they just have so many things going on in their mind. And once we provide and acknowledge their emotions, instead of just countering the emotions, or telling this, contradicting that, saying this, no, you should not be feeling sad, you should be happy that you have treatment options, nothing like that. Because yes, obviously, I understand that, anyone hearing that they have been diagnosed with cancer, yes, definitely people would be sad. So what you're feeling is very true. So but then, what is it that you think that can be done next? What is it that you want to do next? So give, acknowledge, and then ask a question. So they would open up about things that they want to speak about. So yes, and just one point that I would like to take it an end is that, you know although as clinicians we are like experts in diseases and treatment, but only the patient is expert in their values and the trade-offs they are willing to accept. So we cannot decide what the patient, can trade, saying this, yes, I understand that you don't get to see your daughter getting married, but at least you would be there until your son is completing his education. No, nothing of that sort, because patient has their own value. We cannot decide what they can trade off, what they can, what is better option for them, because they might have certain values which are more emotionally attached to certain things, rather than that might not seem very significant to us, but that is different for them. So we are experts in diseases treatment, but then only the patients are expert in their values, so they should be making the decision, for which we have to acknowledge, respect their their points that they are making, and give them the space to actually get clarified on what is it that they would want to know. So yes, with this I stop here and I open the forum.
Thank you so much, Dr. Revathy, for that wonderful presentation. Participants, you can post your questions in the chat box, or else you can raise your hand and then unmute and ask. For the next 5 minutes, we can take up questions and then we will move with the case discussion.
Can I ask a question?
Yes, Dr. Dilip, please go ahead.
Yeah, ma'am. One question we frequently encounter, um, many times the patient is, say, in fourth stage and almost inoperable. So, like in big institute, we always tell them that one should now take care, and there's no point in doing any further management, including surgeries and all. And the same patient goes in private setups, many. So most of the private setups will always give option, and then they unnecessarily do surgeries and those kind of stuff, which always happen in many of the privates. So there's a big dilemma in this. So how do you address this?
Uh, I'm sorry, I didn't get your question properly. So, dilemma in decision making, or
So,
you're
so
asking?
what happens in a big institute and government setup? So when the
Yeah.
patient is in the final stage, so we always advise that further management is not advisable and one should not do it,
Yes.
and only palliative care is, should be taken care of. But the same patient, when
Yes.
they goes to private setup, say private, say
Yeah.
a small hospital or even big private hospital, they will always
Yes.
tell that there is hope and they should take a chance to operate when possibly they
Yeah.
also know, but it always happens that, and then patient ends up into spending a lot of money, and so this
Yes.
issue is always there.
Yes, yes. So that's a very right question. So I would give you my opinion, because again, I'm not a complete expert on treatment planning, but then I would definitely speak this in from the patient and the caregiver's point of view. See, when especially we encounter patients who are in their end of life care, or who are in their palliative with the advanced disease. So what happens is, the caregivers usually try to give their best to the patients. They always would want to, fight for until the last moment. They don't want to give up, because that would create a sense of guilt and regret with them, when they feel that, when if the doctor says that, even if it is the smallest thing, if the doctor says that, actually you can either do a surgery, but again that would not give complete result, but that can possibly try to extend their lifespan, but still the disease is going to be there, or that could have both equal effects. It can Patient can either get relieved or not. So even if the chances are very very limited, usually the caregivers always try to generally go ahead and take that option, because they don't want to be left with the feeling of regret later. They should not be, they like, if there was something that I could have done, why did I not do that? So that was with the point that, the caregivers always think with, and that is why they always say, is there something that can be done? Is there something that can be done? But most of the times, what happens is, patients that we encounter here, with my experience, that most of the times patients do not want to go through any serious treatment procedures, especially when they know that the cure is not going to be there, or it's not going to yield very satisfactory results, because that is again putting them through a lot of physical effects, be it surgery, because recovery from surgery is going to take up a lot of time. So that is going to require a lot of physical energy. So there are points that the patient considers. So that is why we always, when we speak with the patients or the family together, or regarding treatment plans, especially in advanced cancer setting, when we speak to the caregivers, we tell them that, see, these are the options available. And we understand that as a caregiver, as a daughter, you would want to do things, for your mother. You would definitely want to try out things that would, help her. But at the same time, you should also know that these things have these physical effects, and it should be put out in front of them. And patients choice should also be given a lot of importance there. So you can introduce and tell them that, see, these are the things that would require if your mother is going to go through surgery, and like, what is your mother's opinion about it? What is the patient's opinion about it? Or what do you think she would feel, or how would she feel? So I think that factor should be introduced when we are communicating about treatment planning, especially in advanced cancer settings. So we have to acknowledge again, we cannot blame the caregivers. We cannot tell them that here we are telling it's not curable, but then again another hospital telling that they also tell that it's not curable, but they are doing surgery. Yes, caregiver would try to attempt to do anything. Even if we are in their position, we are doing it for our loved ones, we would definitely want to do, okay, this would give 1 week of relief, still okay, go ahead. But then we don't know what we are putting through the, what we are how much we are putting the patient through it. So that we have to acknowledge that and address that also. Tell that, yes, I understand your intention in going ahead with this, choosing this, but if the patient is also aware of these things, like, the pros and cons of all the treatment options, and then choosing to go ahead, then well and good. Otherwise, this should not be done with just the intention of, pushing the guilt away. That should not be the case.
Okay, thank you.
Any more questions? And as Dr. Revathy, I think what you spoke about regarding the previous question was something perfectly right, because that happens in everyday scenario. We see a lot of patients, especially the caregivers, coming to us. And usually in end of life care scenarios, even with respect to nutrition, this is the question that we encounter. Like, patients, caregivers coming and asking, why don't you start them on a total parenteral nutrition? Though as physicians, we know very well that it is not going to bring a lot of benefit for the patient who is dying, and it is going to put him under even more burden. So, yes, communication plays a major role in such situations where we need to sit with the family, the relatives, especially the primary caregiver, and make them understand that it is not going to be of any benefit. So we always outweigh the benefit versus risk, and then only we go with certain interventions. So we should think in that aspect, and then we should move forward. I think Dr. Revathy was also trying to tell the same thing, and she had given a lot of inputs from the patients and caregivers, and which actually adds a lot of meaning to that question. Thank you, Dr. Dilip, for bringing that question.
Very true.
So I think we can move with the case presentation for today. I welcome Dr. Lorna Fernandez for presenting the case. Over to you, Dr. Lorna. Dr. Lorna, you're muted. You're muted.
Sorry, yeah. Good evening, everybody. Good evening, Dr. Revathy, Dr. Hashmat, and all our participants. Yeah. I'm Dr. Lorna Fernandez, my project coordinator with Compassionate Community with the Palliative Care Center, South Goa. So my patient today is a 71-year-old male with a diagnosis of hepatocellular carcinoma. Next. The patient came to the palliative care OPD on the 20th of March 2024 with a history of decreased urine output compared to before for the past 2 weeks, abdominal distension of 2 months, and breathlessness on walking for 2 months. Yeah, the history of his illness. Yeah. Patient had a history of weakness for 2 months prior to the diagnosis. History of abdominal pain on and off, and sometimes he had cramps and some dull aching pain which starts while lying down. History of jaundice was present, and patient was diagnosed as hepatocellular carcinoma at 1 stage on the 1st of March 2024. And after that, he was referred to the palliative care center in South Goa. On the 20th, the patient came to the center. So patient was continuing, as he came to the center, he said he was continuing to take treatment from a private hospital where there was a visiting oncologist. Patient is also a known case of hypertension for the past 10 years with diabetes 2 years. And he had a past history of regular alcohol intake for many years and no history of smoking. There's no family history of cancer in the parents or siblings. And there's history of hypertension in 3 of the patient's siblings. Yeah, next. On examination, the patient was moderately built. His pulse 98 per minute, BP 114/72 millimeters of mercury, respiratory rate was 16 per minute. He had pallor and icterus. Pedal edema was there, and his CBS heart sounds were normal. RS was clear. Abdomen was distended, and there was a dull note on percussion. CNS, there was no obvious neurological deficit. And next. His investigations, the HB was 13.8, WBC count was 4,470, platelet count 1.2 lakhs. Urea was 26 milligrams, creatinine 1.1, uric acid 4.1, this serum bilirubin 2.1, slightly raised, minimally raised, direct bilirubin 1.4, indirect 0.7, and his SGOT, SGPT were raised to 32 and 127. Proteins 7.2, slightly raised. Albumin 3, globulin 4.2, Ag ratio 0.7. Alkaline phosphatase 295. Sodium 132, potassium 5.3, and chlorine 79. So actually only his SGOT, SGPT are showing derangement. So his psychological aspects, patient is a 71-year-old, case of advanced CA, living with a 68-year-old wife and 2 sons aged 32 and 30. Both sons were unmarried. They are from a middle-class family, and the elder son is the decision maker. And both sons were working. So the father is concerned that he has to settle the family matters regards property and settling both the sons who are not married. The wife feels helpless and worried as she can see that her husband is not getting better with the treatment. And also she's worried how she will manage if something happens to her husband. The sons are worried about their father's condition, as they have been told it cannot be treated now and they'll need just palliative care. And they want to know what they can do for him at this stage. They also feel that the parents may not be able to cope if they are told about the illness. Next, the medications they are taking was mainly symptomatic. So lactone 50 milligrams, half 1, pen 40, 1 tablet, propranolol 20 milligrams, twice a day, BD, tab megasterol. This was, I think, started by the oncologist, 1 a day, and dicyclomine, cyclopam for the cramps and BD. The patient's main concerns are his distension in the abdomen is increasing and he's getting breathless. He's also worried about his worsening illness, and he wants to settle his property matters and the marriage of his sons. The family members' concerns are worry and anxiety, as the illness they've been told it's cancer and cannot be cured. In the summary, the 71-year-old male patient is the case of advanced hepatocellular carcinoma. Patient and wife have not been told about the diagnosis and prognosis of the illness, but patient is aware that he is not getting better. So the discussion points here are how to communicate with the patient and his wife regarding the illness and prognosis. Then a discussion or meeting with the son and family members regards what to inform the patient and how to approach the patient regarding his last wishes. Yeah, thank you.
Thank you, Dr. Lorna. If you can just add a few points on how you went about in managing these discussion points that you have mentioned here, it would add a lot of value to the discussion, and then Dr. Revathy can also add her comments.
So the patient was brought to the palliative care center, and I mean, he was referred from I think he was diagnosed at medical college, and was told by the sons that he could not, nothing much could be done. So the team sat with them, and then they asked them, like, asked the patient what he was feeling and how, what he expects, and even the sons and all. I think they spoke. But when they spoke to the children, the son, they had said, patient was also brought at that time. The son said, told the team first to me that they did not want to tell the patient, like not want to use the term cancer. Though the patient knew that he was not well and he was feeling that he was getting worse. So the team asked the patient, like, they spoke to him and made him comfortable. And then they asked him, like what does he want to do, like, about the treatment, and what does he have any plans for something. So they were able to get that he wanted to do a certain puja, and so he could tell about what he needed to do, and also his concerns about his sons not being married, and a few property matters that he wanted to settle. And then, of course, regarding his symptoms, it was mainly the breathlessness and some cramps and discomfort. So he was given mainly symptomatic treatment, and I think that megasterol for his appetite and whatever, since he was not in the terminal phase with the meds and all. So the sons were, they also sat and they counseled the sons regarding what like how to carry out the treatment, and how to manage this patient at home. And after that, they were put on weekly home visits where the teams would visit the patient at home and find out what they were doing. So as they went for this home visits, then they found out that the patient was managed to do his puja, and so he was a little settled relaxed in that manner. So then they also spoke to the wife and tried to make her understand, like, how the patient is, what treatment they can give as of now, presently. Yeah, thank you.
Thank you, Dr. Lorna. Dr. Revathy, would you like to add your comments on the same?
Yes, yeah. So thank you, Dr. Lorna, for bringing up this case. So, as you were telling, you had mentioned that both the patient and the family cousin and the wife were not aware of the diagnosis that it's cancer, because the sons do not want to use the term cancer, whereas the son is the primary decision maker. So this is a very typical scenario that we frequently encounter, especially when we are dealing with geriatric population, because children always want to protect their parents and think that they are aged and they would not be able to, their mental health would be disturbed, and that anyways they don't have to know about the finances, they don't have to know about treatment options and all of these things, because again the caregiver's age also matters a lot, because when the carers are somewhere in the young adult and adulthood phase, they feel more responsible for making decisions about their families. So in that case, they do not involve the people into the picture, so patients into the picture. But here you said that the patient is already aware that he is not getting any better and that his health is getting worse. And the wife was also wondering that, his health is not getting better. So it shows to me that they both are already, except for the fact that they don't know that the name is cancer, they are aware that their health is deteriorating. The patient's health is deteriorating. And that is why he is bringing up the concepts of last wishes as well, because that, he wants the sons to be settled and he wants things to be done. So in that case, if the patient again is not comfortable or not suspecting cancer per se, and the family does not want to use the term cancer, then you can definitely, stick with that. But, if the patient is insisting and asking whether, some scenarios you would be having patients who are asking, is it cancer? Do I have cancer? Tell me. I'm just, people are talking about this, but I don't know whether we really have cancer. So if they're insisting on knowing whether it is cancer, then yes, we have to, ensure that we have a discussion about that. But here in this case, I feel the emphasis is more on the patient's need for information is also emphasized more on knowing whether he is going to get better or not, just to make plans for his future, because he is already old and that his two sons are not married. So he just wanted to complete a few responsibilities that he wanted to do. So not in terms of knowing the diagnosis per se, whether, I want to know if it is cancer, what is the term, what is my diagnosed with. So in that case, you can assure the sons about this and saying this, why is it important for your father? And, you don't want to use the term cancer. And I agree to be in line with that. But I think it is important for us to at least discuss his current scenario so that we can get to know what is it that he wants. Because yes, you are trying to provide the best for your father and your mother. You are trying to give the best physical health, and you're trying to protect the psychological health as well. But it would be more ideal if we get to know what is it that he wants also. So for that, I think it is important for us to have an open communication. So why don't you also be a part of the communication? And I assure you that I would not be using the term cancer to mention that, because that is what the son is also anxious about. And I don't think there is a need for that terminology with the patient as well. So they just want to be clear on what is the scenario that they are dealing with. So in that case, you can include the son. And what happens is, sometimes when we involve the caregiver and you open up a discussion with the patient about asking them, so what is it that could you tell me what is going on with your health? When they start speaking, sometimes that becomes a revelation moment for the caregiver also. They would get to know, oh, my father knows this much already, oh, he is aware of this already. So because they don't actually have that open communication, the children usually they have their own set of thoughts, they stay with that. And the patient would be having their own set of thoughts and he would be staying with that. They don't communicate because they feel bad for, they feel worried about harming each other. If I speak about it, he would feel bad. If I speak about it, he would feel bad. So that would be the pattern. So they both would not be aware of what exactly they both know. They would assume that my father does not know anything. They would assume that my son does not know anything. So it is our duty to bridge that gap. So you can just, you can tell the son, assure the son that I'm not going to, introduce any new terminologies or introduce any new information, but I would like to know what is it that your father is thinking about this. So why don't you also join the session and we would just, understand what your father is thinking about this. So you can just initiate a conversation about what is going on with you, and what do you know about your health condition, and what's it that you want to do. So you can have this communication, and wherever you feel that there is a gap in the information or where there is a need, without using the term cancer, you can still explain the scenario to the patient, because that is what he wants to know. So, and then you can also explore on what are the things that he feels that he wants to do, because, in terms of last wishes or anything, once the acceptance has come. And sometimes when such conversations comes up, when they start listing out, these are the things, I just want my both the sons to get married, I want this to happen, I want that to happen. So there will be a lot of things that actually comes in. So, but then not everything would be practically possible. So, but then first you can ask them to list out things, just list out whatever comes from them. And then slowly we can take one thing at a time and ask them, okay, so based on the discussion we had, and I had told you about what exactly is your condition right now. So what do you think would be the possible things to do from this list? What all do you think we can actually, work out? So then we can set realistic goals for them. So these are the things. So slowly they would come in acceptance that, okay, these are the things probably I would not be around to see if it happens or not. But these are the things at least I can try and see if I can work it out. So they can come in terms to reality. So I think you have to respect the son's position also here in terms of
Yeah.
not disclosing this, but at the same time we can provide the information to the patient, just explaining in terms of the scenario, not using the term cancer, and you can have it together so that they both are on the same page once the conversation concludes.
Thank you, Dr. Revathy.
Yeah, thank
I
you.
think
Thank
a
you.
few
Thank you for
things he
bringing this.
got to do because he got to do his puja and all. And
Yeah.
so that was, and the team was following them up weekly on home visits after that.
Yes. So that was very good actually,
And the
once you said that
counselor also had visited so that she could speak to the wife and all of them like together and separately also. So they
yes,
could
yes.
manage to do some
Okay.
intervention.
Yeah, so actually that was very good when you said that, he started doing his puja now that he was feeling calm about it. So it really showed that, you are working on the right goal there because, you enabled him to do things that meant to him. So that was provided. So I think once we provide a little bit more clarity on his situation, then he would actually start, fixing up more rational goals and can start working on it. That would definitely improve his quality of life.
Yes, I think that is the right response to how we will handle this situation because we often go by this way. What Dr. Revathy was mentioning, we need to explore the insight of the patient regarding the disease, the illness. So when the family is there nearby during this conversation, they will also understand that the patient knows a lot of information already, and then we can have what we actually do is during that discussion most of the time we try to remain calm and allow the patient to come up with all that was there in his mind, and after that talk to the family once again, making them understand that the patient knows all of this, and then would you like to go and break the bad news once again. So maybe step by step we will approach that, and after we start this conversation usually the patient also comes up again and again with certain doubts like what is happening with me, can you be even more clear, and all these questions come up. So that is how we move with the discussion. So that plays a major role in our everyday practice, right? So I think Dr. Revathy has coupled all that up and she has told everything in detail. I hope that helps. And with respect to the management of his symptoms, I would say for abdominal distension, we can go with an ascitic tapping, which will relieve his distress definitely. And that can be done even if the patient is in end of life. So end of life can vary anywhere between, it is like,
That was planned for him, yeah, correct.
Yes, so that would relieve his symptoms a lot, and also for the breathlessness. So once ascitic tapping is done, he might be feeling much better. And along with that, if still he has a breathlessness, you can also add a low dose morphine, something like 2.5 milligrams BD or HS, so that helps with the breathlessness part. So I think that would have been a much more better management of how maybe in future when you see such cases and when our participants also come in contact with such cases, I think this can be done. We usually do ascitic tapping mostly just before we understand that this patient is dying. Definitely we are not going to do in that dying phase, but just before that, maybe even a day prior to the death, we have actually done ascitic tapping in our inpatient units because we always look into comfort, and then if they are ready to go for it, we definitely have to do it.
Yeah. Thank you, doctor.
Thank you. Any more questions from participants' end? And Dr. Revathy, would you like to comment anything?
No, I think you actually summarized the points that were discussed as well. So I think I know it was in line with the presentation topic as well. So that was a very nice case to actually discuss following the presentation. So thank you, Dr. Lona, for bringing up the case. So yeah, that's it from my end.
Thank you, Dr. Revathy. Any more questions from participants? Would anybody like to ask any question?
Can I just add this palliative care in South Goa? We could take that reference from Dr. Kalyani. She presented the case, Madkai. So maybe if she refers, Dr. Kalyani had presented in the previous session a case. So if she could refer to the palliative care.
Yes, Dr. Lorna, we've told the relatives about the palliative care center in South Goa District Hospital.
And even if the patient doesn't come, you can just send the daughter with all the details, and then after the team can visit them at home. So if you coordinate
doctor.
that, yeah. So that way,
Yes,
even the
thank you so
others who
much.
have any cases, yeah.
Thank you so much. So if there are no more questions, I think we can close the session for today. Before that, we would like to apologize from our end. We have been facing some technical issues here at our end, and that's the reason why our videos have been off for quite a long time. And we apologize for that. And I hope the session was really good. And Dr. Revathy had done a very nice presentation. And actually, Dr. Lorna had also brought in a very good case for presentation, just like the previous session. Thank you so much, participants, and over to you, Gayatri.
Thank you, Dr. Revathy and Dr. Hashmat, for the wonderful presentation, and thank you for joining us. Thank you all participants for the joining and your time. And I hope you all found the session much informative, and we are looking forward to see you on the next session. Thank you all.
Yeah, thank you.